we're going to jump into the next section, which is sort of a what would you do section, which I'm super excited about. And we'll maybe get a little more into the specific nitty gritty of some of these lenses just based on clinical scenarios. But I'm going to start with a couple questions first that are maybe applicable or theoretical. So first, if you guys were having cataract surgery and you had the choice of doing your two eyes a month apart, a week apart, a day apart, or the same day, what would you choose?
Closest to
Tanner,
surgery goes first.
Oh, Tanner.
I didn't hear what you said, Brandon. You spoke way too fast. I would have mine done on the same day, especially if Brandon was a surgeon.
Oh,
Wow.
me too. Maybe we can do each other's on the same day.
Great.
I would do the same thing. I would.
I'll do the surgery. I'll do the surgery first.
Keith, what about you?
I would probably do them a day apart.
Okay.
I've been lucky enough so far in my life to never have any eye surgery, and so I would probably have just a little anxiety, even though I see it every day. I see how well people do. I always think about back to the time that my wife had LASIK, and I was so nervous, even though I've seen hundreds or thousands of ANSYS LASIK patients do beautifully. Just from an anxiety standpoint, I'm a little nervous Nelly, I guess. I would probably do one eye in one day. Kind of like what we're doing now. We'd check that eye the next morning, make sure we're all feeling good about it, and then do the other eye the next day.
Perfect. Yeah, and I think just as a point of reference and good to know, I mean, for the last 5+ years, we, in Montana, and I think a lot of our locations, probably 95% of our cataract patients, choose to have cataract surgery a day apart or a couple of days apart. And again, it's reasonable to do a week or 2 weeks apart, but the beauty of sequential one day apart is it's one healing phase. They get back to normal and back to life as normal more quickly. For family members who are driving them, it's just much, much easier. And I think the one logistical hurdle and financial hurdle that prevents us from doing same day right now is just the insurance aspect. So there's managed care organizations like Kaiser and the VA and other places outside of the US who have published enormous databases of information and case series of patients where the safety is really spectacular. And so hopefully one day, by the time Tanner and Brandon need surgery on the same day on each other, we'll be able to do that from an insurance perspective, which is nice. So we're going to kind of just do a case where I thought it'd be fun actually to start with, and then we'll jump into some kind of more squirrely cases. But first would be just for your own eyes. So your own eyes, if you were having cataract surgery today with the technology that we have, what lenses you would be choosing for your eye. And you can maybe kind of walk through in terms of, are you emmetropic, nearsighted, farsightedness? What's your ocular history that might impact that decision? So Keith, I'm going to let you tag this first since your eyes are perfect and you've never had anything wrong with them.
But you're also asking me because I'm almost 47 and I'm getting a presbyopia right now. So, I actually am starting to have to stretch things out a little bit to see a little bit more. And so I am valuing my near vision more now than I have in the past couple of years. And with the advancements of multifocal implants, I think for me, it'd be a no-brainer. I'd do a multifocal implant. I want to be able to see my kids out there on the ice and be able to see the program and see my watch and those sorts of things. And I don't do a ton of nighttime driving, even though halos have been minimized. Nothing great happens after 8 o'clock anyway, so I'm in bed early. And so for me, I think it's an easy decision.
Good luck.
Multifocals.
Keith, good luck as the kids get into junior high and high school and start
I
checking home
know.
late.
8 p.m. curfew in the Rasmussen house.
I know.
Once
they
my
can
dad
drive.
goes to bed at 8.
Oh boy.
Brandon, what about you, bud?
The perspective is a little more challenging because I'm not presbyopic and I'm probably not even close. But here's my thought process right now. In all honesty, I have had LASIK and I had quite a bit of astigmatism in my LASIK prescription. And I've been following, obviously my topographies and my epithelial thickness maps, and I've got, not a super normal epithelial thickness profile. And one of the thoughts, of course, anytime we're going to choose, a technology with a patient, we say, what's my likelihood of success here? And I think even post LASIK, the formulas are so good that the likelihood is still really, really high, that we'll nail it. And then what am I going to do if I need to adjust? Like, is there an adjustment plan for this particular patient if there's a little residual refractive error, right? Because you need to have those things thought out as a refractive cataract surgeon these days. So for me, I really, really like LAL technology. That's the light adjustable lens. I think I've seen particularly post-refractive corneas do so beautifully with this technology. And we have so many happy patients, especially with just a little bit of blended vision, that I think that might be the direction that I would go. Although a true multifocal would be really, really tempting to me, I just wonder about how particular I am and how my LASIK would play with those diffractive optics. We have a ton of patients that we use PanOptix post LASIK in, and they're very happy, right? But they're also presbyopic and super motivated, and I may get there, right? I may get there too. But right now, I'd probably say LAL.
Sweet. Tanner.
Yeah, I was actually having this debate when, you sent over the questions ahead of time. I was having this debate in my head whether I would go LAL versus PanOptix or like a trifocal. I don't know if I'm a very particular person.
We'll
but
ask Kayla.
Yeah, we know somebody who
that-
would know.
I have that fear too. I could see myself being particular at distance and wanting to maximize my image quality at distance. But my image quality has always been great after my LASIK. I never had any issues with halos or seeing at night, things like that. So, and Keith took a look at my flap immediately after my surgery. So I know it's pristine, advanced in my LASIK. So I feel comfortable that even if we are off a little bit off target with the multifocal IOL, that it's a flap that's safe to be lifted. So I probably would land on a trifocal and
Yes.
take on multifocality.
Perfect. For my own eyes right now with the technology that's out there, I'd be in Brandon's boat. And a little history there. I was a previous, -625 spherical myope. So I have, a relatively flat cornea. Had thin corneas to start with, so I had PRK. And so I don't have a lot of room for flexibility. And my higher order aberration profile is on the higher side. So for me, just from a vision quality and ability to kind of enhance and refine that refractive target, for me, that's where LAL would be a nice win for me if I were having to have cataract surgery right now. So I'm going to throw out another case because this maybe applies to some of the new technologies that we have, and particularly how we think about a standard monofocal or a toric, an extended depth of focal, a light adjustable lens, or a pinhole optic. So I just had a patient last week, previous 8-cut RK, mild irregularity to their cornea, but less than 2 diopters, had about a diopter 1.25 on one eye, 1.5 diopters of astigmatism on another eye. Like many patients who had previous RK, interested in some refractive freedom, particularly for distance. They'd love full range of vision, but realize that maybe isn't possible, and is curious what would be kind of the best lens options to give them better nighttime vision quality and maybe a little bit of range of vision. So Keith, I'm going to let you take a swing at this one first. What range or what kind of lens choices are you thinking about in this patient? And do you have a go-to for this one?
Yep. One of the first questions I'd ask that patient too is, how was your vision right after you had your RK? If it said it was amazing, that opens up a few more choices, whether it's light adjustable lens, pinhole, IOL, or even an EDOF. In our practice, I would say most of those patients were using light adjustable lenses. I feel like this is a sweet spot for light adjustable lens. We put the implant in the eye. We wait probably about 2 months, especially post corneal surgery. Sometimes those refractive changes can linger for a little bit longer. But the cool thing with with people that have had previous RK is they have almost a little bit of multifocality built into their cornea. And so when you do a light adjustable lens and you target one eye plano and the other eye -0.5, -0.75, with that multifocal cornea, those people are reading really well. And so those are actually some of my favorite patients to work with LAL. Now it's a journey, and patients have to understand that it's several months, but those have been some of my favorite patients to work with. And most of the time we're doing LAL.
Beautiful. Brandon, what if we took that same patient and instead of 1.2 diopters or 1.5, they had more irregular astigmatism and maybe 2.5 to 3 diopters of irregular astigmatism, and they particularly even pre their cataract have kind of been frustrated by their nighttime vision quality, and they have a little more irregular corneal topography. Would that impact your decision in terms of what lenses you're thinking in that patient?
It certainly does. One of the important kind of forks in the road for us when we're thinking about irregular corneas is this eye, for best vision, is this eye going to be contact lens dependent, right? Is their best vision really going to be just a lens, or are they going to need like a scleral lens, right, to see their best? I mean, keratoconic or RK or you name it, post-keratoplasty, we've got a ton of irregular corneas out there. And so I always try to decide, like, are they going to be looking through a fluid dome and normalizing that cornea, and we're going to want some other type of optic in there? So that's a decision point for me. But when you're talking about more of the higher order aberrations, and of course the light adjustable lens corrects aberrations, but only the lower ones, right? And so when we're talking about really aberrated corneas, we're starting to say, okay, do I want to consider doing an Apthera, right? Apthera being the pinhole IOL, which can help kind of eliminate some of those peripheral light rays that end up scattered and causing contrast problems and reduction in visual quality. Can we improve that with one of these pinhole IOLs? And if not, we have, even in the cornea you're describing, Russell, we have seen success with the LAL, right? When you can't really identify how much of those lower order aberrations they are on the cornea, where that prescription is going to wind up. If they say, hey, I want anything possible to maximize my vision without the dependence on contacts or glasses, then I think, LAL can still be on the table, right? Apthera is on the table. And then when you get to the really irregular corneas and they say, I really need to see better, or they're already contact scleral lens dependent, then we might be having the conversation about a monofocal being the best choice for them, because we don't necessarily want to go down the road of having a oddly shaped advanced optic or a toric and having to do some fancy stuff with contact lenses afterwards.
Awesome. Tanner, any other thoughts on either of those two scenarios?
I think in the more irregular cornea and, looking closely at topography, and depending on the extent of irregularity, I think it's a good opportunity to use a gas perm over refraction. So they don't have much cataract and they're like, 20/40, but then they improve at 20/25 with a gas perm over refraction. That might mean they could benefit from an IC8 or an Apthera, a pinhole optic. It might also mean that they're going to be contact lens dependent. And then the only other thing I would add to this discussion, because I had a patient like this, is I, like Keith, prefer the LAL in these post-RK patients. I've been amazed at the outcomes. But you have to remember the dilation, because you need adequate dilation for the light delivery after the surgery. So I had a patient recently who had 4-cut RK and had a relatively normal topography for a post-RK patient, and loved his vision after RK. And so we actually did an EDOF in him because he only dilated to 5.5, and he's been doing great. So
nice.
It's great points, and really, really solid reminder again, because those adjustments happen post-operatively. We want to see them dilating greater than 6.5, ideally maybe even 7 pre-operatively, to know we'll be able to get complete focus on the IOL optic at the time of the adjustment. So that's super great. Okay, so one of my other favorite class of patients is, we'll just call them the particular type. So, we sometimes use a Dell questionnaire, and it's like, hey, I'm like super easygoing, or like I'm super type AAA and very, very particular. And they kind of right to the right of that spectrum, like I'm even more particular than a particular person. And they might be a pilot or they might be an engineer. But let's say, Brandon, I'll throw this one at you. You have a near emmetropic patient like Keith, but they're a little more particular than Keith. They're a pilot, and they are, they would like the most visual freedom that they can have, and they would like the most visual range that they can have. And oh, by the way, I also want the absolute best optics that I can have. What things are you thinking about there for lens choices? What advice are you giving to that patient? What considerations are you making also, even just in terms of like, are they a private pilot or are they a commercial pilot? Maybe walk through something like that.
Yeah, this is really good.
I saw a pilot today.
I did too. So, okay,
It's also a good case.
This is going to be really good. Okay, here's the case. Okay, he's a 63-year-old neurologist, very particular, very smart man. Studies epilepsy, right, in children. He does remote work and he flies himself in a Comanche, right? So, he wait, did he say? Okay, it's some sort of small aircraft, right? And he's dependent on his vision. Best corrects to 20/30, 20/40. And he's historically kind of a habitual -2, -3. He kind of lives with his glasses off most of the time in practice. And he has been wearing multifocal contacts and has loved them. Even as his cataracts has developed, he's loved them. He flies with them. He flies at night. And he doesn't seem to be too bothered by this, right? And so he came in with the strong interest in a multifocal. And I'm gonna flip this around because I have some thoughts, but I'm gonna go to Keith. And I'm gonna play the point of the moderator here. And I'm gonna say, given his desired near point and occupation and recreation as a pilot, what do you think about your ability to meet his goals and keep him safe with different types of lenses that we have available to him?
Mm-hmm. Now, did you say, is he okay with wearing either glasses or contacts afterwards, or does he want to become?
He wants to be as free as possible.
Okay. What gives me some peace about this one is he was flying around with multifocal contacts and a cataract, and he was doing fine. I think it's still, you have to have a huge conversation with him. You have to document this, that there's a chance you put these in, and this can make you see better. You might even see some of the aberrations better. Little glare, a little halo. Now with neural adaptation, that generally lessens over the course of a year. But if we get,
I don't know if he'll get neuro adaptation. He's a neurologist, he might, he might not buy into that. Keith.
He should understand that more than anybody. But if you get a few months down the road and nighttime's too much of an issue for you, we're talking about an implant exchange. And if he's still that motivated to go after it, I'd be okay with multifocals. We've done multifocals in truck drivers and pilots, but it's after an extensive conversation, and patient has to have some motivation on their side to want to do that. It's also the beauty of light adjustable lens. If somebody's not sure, you get multiple choices to adjust their vision. Now, they're not going to be as independent from glasses, but for some of those patients that are sitting on the fence and they don't know how much myopia they want or monovision or distance, that's right up the alley of light adjustable lenses. You can set them at one spot, let them live with it for a little bit, and make adjustments along the way.
Those were precisely the two things I described to him this morning, right before I got on this call. And he's considering both of those things. And so this is one of those times where I think education plus a little bit of time is going to be really important to patient satisfaction here. And I think that case highlights it. I don't have the answer right now for him because I'm not exactly sure which way he's going to want to go, or I'm going to, agree to go with him. But I'm thinking I can be successful with either the LAL or a panoptics or a trifocal lens. Commonly, I choose a panoptic lens, but one of the other considerations is he's a habitual -2.5, right? So his near point is here. And I said, And I had him hold him up. Where's your near point? And where do you read? He puts his hand up here, and I reach up and I grab his hands and I slowly bring them back. Are you okay if your near point's here? And he said, yes. So, it's one of those things where if you don't have a conversation with a habitual, mild to moderate myope, and you're going to put in a trifocal lens, which is going to make them super happy at distance, you have to make sure that they understand where that focal point is going to be and how they're going to have to adjust to that too. Tanner, is your pilot similar to my pilot? Are we seeing the same guy?
He was getting a second opinion after he saw me.
Yeah, second opinion.
That's right.
Actually,
He drove immediately to Omaha after he saw me.
Yeah.
There's a lot. I think there's a lot of good points in that case. Going back to what we talked about in the beginning of the podcast with preoperative, historical point of history of multifocal contact lens wear. As soon as you said that, I thought to myself, if he wants maximum freedom from glasses and he's tolerated multifocal contact lenses, he's probably going to do just fine or do well in a trifocal IOL. And then, as you mentioned before, if it's a habitual myope, having a long discussion with those patients about, a near point after surgery, because a problematic near point is a big source of dissatisfaction after these types of lenses. So my patient, a little bit different story, but he's a private pilot. He's like 64. He has very asymmetric keratoconus. So he only really has keratoconic changes in one eye, but it's not severe. I think his K max is like 51. And he's probably got $3.5 a sil. I think he's been wearing a contact in that eye. And then his other eye's topography is completely normal, but similar to Brandon's patient, very motivated, wants as much as possible to have reduced reliance on glasses. I was leaning towards like a pinhole aphthera in the right eye, the one that's got the asymmetric keratoconic changes, and then like an EDOF or an LAL in the left eye. And I landed on wanting to do an LAL because he's got the keratoconic changes in this eye, which means he's probably got some type of underlying structural weakness or propensity for weakness in his cornea. So I don't want to necessarily have to adjust that left eye. So that's the plan we talked about this morning. I'm curious if you guys have different thoughts.
I think it's a great plan, Tanner. I think the only thing that I would wrestle a little bit with just the right eye. And, I can't remember. I think you said he's currently in contact lens. I'd be really curious how well he corrects with glasses, because if he corrects well in a soft contact toric or glasses,
I think he gets 20/30.
Yeah. So with that amount of astigmatism, I might lean more towards even an LAL in that eye, because I just don't know how much, with that 3 diopters of irregularity, the pinhole, I think that there's an art and a little bit of science to how much benefit or reduction you'd see in the effect of that. And if he's okay, still maybe being in a contact lens afterwards, I think it's still a great option. But I think, again, it's the beauty of having all these different choices where we didn't have those before, that there is some consideration to there. But I love it. That's another great case.
Did you do a gas permeable refraction on him? And if so, did it improve him a lot, or was it?
Yeah, but only by like one line.
Okay.
Yeah. Cool. Well, great cases.